Hold on. All right, hello America. We are back. There's been some drama, as in we screwed up our initial posting.
We don't remember how to do the show.
Yeah,
That's what it
we
comes down
haven't been
to.
here in
We
like three
literally don't
weeks.
remember how to do the show. We have
Like,
no freaking
I don't
idea.
know. We like took a vacation. There's like updated settings. We don't even know what's going on. Anyway, turns out we did the wrong time. We set it to go live at 3 a.m. So here we are. Anyway, we have a special guest who may or may not be joining us, depending on
We're
if
not
she's
doing
able
great.
to get into our StreamYard.
Although you know what I will say, because I did record another podcast this morning and we also had technical difficulties, not on this platform. So it might just be like, I don't know, like some kind of moon situation. I don't know.
Do you think it's Russia?
Could be Russia. Could be Russia. They're
Yeah,
messing with our podcasts.
I mean, that's the thing. I also am having some torrential downpour here in the south. We'll see if the
Cool.
infrastructure still holds up. Okay,
Yeah,
America.
good deal.
We have not been here for 3 weeks.
Oh my God.
So much stuff has happened. We probably missed a lot of it. We're gonna do what we can. We're gonna do what we can. All right. So our special guest, should she be able to log in, is Melanie Bush, the new head of North Carolina DHHS. What? As you guys know, we've had, I think, most of North Carolina on our show.
Yeah, we it's a great state. They do cool stuff.
Yeah.
And we like them.
Yeah. So we are excited. We're excited to talk to Melanie. In the meantime, we're going to go through our extensive news show here, as well as we would like everybody to know when we Googled what is North Carolina known for, the internet told us furniture. So here we are, Lisa and I, building furniture, which we do in our spare time. So we are excited to hear more soon. But in the meantime, we got a shit ton of news to go through. Stay tuned. Okay. First up, everybody knows this already. Chris Crumpy is going to be the DepSec. What? Everybody loves this guy.
Everybody knows this.
Yep. So
Yeah.
we'll see. I don't think his hearing has been scheduled yet. As we all know, the August recess is coming up. So hopefully that happens soon, because everybody thinks Chris is awesome and it would be great if this happened. We had some other nomination hearings this week. Erica Schwartz, potential CDC nominated CDC director. It'd be great to get a real CDC director. Word on the street is like the hearing didn't go great.
Yeah, Dr. Schwartz. So there's been a lot of reporting about Dr. Schwartz. And first and foremost, from like a credentials perspective, Dr. Schwartz is eminently qualified. Deputy Surgeon General in previous Trump administration. Before that, she was with, I think, the department for quite some time. Yeah, so on the surface, like credentials wise, yeah, dude, credentials wise, like absolutely. Like I'm on board. But yeah, I mean, I don't know. These freaking hearings, like they're just like a clown show, basically. They're a clown show.
They're a total clown show. What I don't understand, it feels like everybody just. There's some big thunder here in Georgia. I don't know if you guys can hear that.
That's thunder.
That's thunder. Can you hear it? It's really, really bad. Yeah.
Everyone, we might lose Kat.
Definitely shut down right now. Like all flights in the country have been halted. Anyway,
be ready for us to lose Kat, because her internet is held together by twine and chewing gum.
Yeah, even on a good day it is. Okay, but here's what I was texting Lisa about today. Okay. So like the big criticism is Dr. Schwartz did not actually really answer any of the direct questions. Like, would you basically stand up for science?
They're freaking minefields. They're minefields.
Trump RFK told you to kill babies, would you do it? And she was like, they would never ask me to do that, instead of, no, I will not kill babies. That's obviously an exaggeration. But so what I'm texting Lisa about is I'm like, okay, like this woman is here like a baller too, and also like maybe the administration's hope to like fix trust in public health. At this point, could she not just say, yeah, Bill Cassidy, I'd say no? Like, what would the Trump administration have pulled her nomination if she said that?
Probably. Like, I mean, I don't think they might have. I don't know. I mean, I just like, I imagine once you get to this point where you're like in the nomination hearings, you want the job. Right. And so do you like, and I'm not saying that in a disparaging way. I just think like once you get to that point, like you've done a lot, like there's a lot going on. You want the job, right? Like you rightfully, like she's, been in these positions before, really close to this. Like she deserves it from a, credential and experience perspective. And so it's like, I don't, but they're all these questions are just like, like, a chance for these senators to just like make their little points. And Cassidy, Senator Cassidy, Dr. Cassidy, you know what? You talk to whatever God you believe in and think about the decisions you made, sir. Thank you.
Yeah, YOLO. But I mean, it is dicey. Like she might not get his vote, and she needs his vote. So like, it sucks too
Ugh.
because, I mean, there's lots of other things he should have voted against. I don't know.
100%. And we are a little short on senators right now.
Yeah, we
So
are.
I don't
Yeah,
know. I don't
things
know.
aren't great there. So oh
Yeah,
my
it's a
goodness,
rough
I think my
time.
house might blow down here. Okay, anyway, so we'll see what happens. Also, I didn't have him in here, but the Asper guy apparently was awful. And said all
Yeah.
kinds of, or not even
Yeah.
subtle. He didn't say anything. None of them say anything ever. But apparently he had some crazy shit on his social
I don't know
media.
this guy, but like in terms of like relatively qualified candidates, like Dr. Schwartz is like on the highly qualified side, and
Mm,
then that guy was like on the side, as far as I
yeah,
recall.
yeah, yeah. Anyway, we'll see what happens with that guy.
Anyway,
I don't know.
good times, good times.
Okay, so other news that I didn't really think was super exciting, but I love the quote. Apparently, the new CIBR guy was like, "I am with you on planet Earth," trying to reassure the FDA that he is not Vinay Prasad and will be doing cool stuff that is normal. I guess they're also revisiting some of the rare disease decisions, which is not a bad thing. Yeah, really good.
I don't think you have in here, but the FDA has, as you know, many different responsibilities, including the poop thing, the
Hmm.
spore of food safety
Oh, you
thing.
know what? I don't actually have that in here, but I don't know why I don't, because that seems like
FDA has
something I would
many
absolutely
really
include. No,
important.
but Lisa, they found it. It's Taco Bell.
It's not Taco Bell. That's so mean to Taco Bell. It's Taylor
It's
Farms.
the lettuce at Taco Bell. I don't know, whatever. Anyway,
Taylor Farms, who are known to do some interesting and questionable things around fertilizer for their iceberg
oh,
lettuce, apparently, and other kinds of lettuce.
I bet it's the
Um,
cheapest, crispiest iceberg lettuce you can buy.
listen, people. I just think here's the thing. One thing we all want is to like be able to eat Taco Bell without having an unnecessary amount of digestive distress. And I just think, I mean, some of it's probably guaranteed with Taco Bell, just to be totally clear.
I don't know.
But
I don't know.
food safety, it's a really important one. I'm sure that our special guest today can talk about just all the things that people in states have to worry about, but it's also food safety. And when the FDA is like not on the case, when the CDC is not on the case as it comes to like outbreaks and things like that, whether it's related to food safety or some other bacteria or virus or whatever else is going on, shoot, it makes it so much harder for state. Makes it so much harder for everybody. I mean, come
Yeah.
on.
I know the
This is
CDC has been getting
terrible.
hammered a lot for the
Ugh.
outbreak. I guess part of the deal was they have not been doing the case reporting or requiring the case reporting on this specific issue. So
Well, didn't
um,
didn't all these places lose like all of their staff who do this kind of
yeah,
work? Like, what are
they
they gonna
lost all
do?
their funding. Now, apparently,
Yeah.
a lot of the results are automated, but also that system that handles, I think, half of the states, Ames, run by APHL, is I believe completely runs out of funding in 9 months.
Okay. Well, there you go.
Yeah, so yeah, we got some problems here. We got
We
some
got some
problems.
problems.
We got some
FDA has some
problems.
problems across different
Yeah,
departments,
we got
including
some
this. Yeah.
situations that are happening.
Situations.
Okay.
Situations.
Also, Lisa, big exciting news that I was hoping you would just tell me about, but then you were
Yeah.
like all sad faced that everybody's just using AI to do their policy analyses these days. So I had to find some myself until you got out of your funk, which probably is right now.
I
So
think
anyway,
Mendel didn't. I think he wrote
does,
this. I
yeah, he does.
appreciate.
No, no, he no, no,
We were
he does a great
chatting.
job.
Yeah, we
I
were
think Mendel does
chatting.
a great job.
Yeah.
I like this guy. I mean, he runs a whole company, care
Yep.
coordination.
Yep.
He's legit. So I actually saw his post first, and
Yep.
then you had texted me sad face about this, which, as everybody
Yeah. I
reads my
mean, oh
LinkedIn
my
post knows,
gosh.
is how I get all my
So
information. So
yeah,
yeah,
you
the
could
big disruption from the
big
physician fee
disruption.
schedule is
Well, so again, so a little context for any policy nerds, right? The Medicare physician fee schedule comes out every year. It's through 2027, has a bunch of stuff. And like, just like in the last 10 plus every year, like CMS is using the basic like fee schedule where they set rates for the next year to do a bunch of policy stuff versus just like putting numbers against CPT codes or whatever. And one of those big things is they were like, hey, what if we made RPM basically legal? remote patient monitoring. And I cracked up when I read this. I was like, okay, well, that's a bold policy proposal, my friends. Basically, they're saying like RPM under original Medicare, it just cannot be delivered by external companies. So right now, there's like these RPM companies who go to like primary care and other doctors who take Medicare, and they say like, we can increase your revenue by like signing up your patients, your Medicare beneficiaries for RPM services. That is a very like biased way of saying it. Like they are actually truly like helping keep Medicare beneficiaries healthy when they can't come into the, between office visits and monitoring conditions.
And we will
But
take
like
a very small, insignificant cut.
that's right. But like that's the view if you're saying like, oh, this is harmful. You're saying, oh, they're just like driving up costs and they're not doing what they're supposed to do. It's actually a really small amount of spend relative to every freaking thing in Medicare. But I guess the administration is saying like this is an area where we think that there might be fraud, waste, and abuse happening, and we want to like really dial that. So what we're saying is no external parties. If you want to do RPM, we'll pay you for it, but they have to be people who are employed by your practice, not external parties. And that's just like a massive, massive change for how this has been structured. So
It
very
also wipes out a
interesting.
whole sector, or not
Wipes out
not
a sector,
like a
a sector who, by the way, is like absolutely like firing up their engines right now to like drive as fast as they can to Capitol Hill and go. They're like,
they're going.
hello,
They're going.
we
Yeah.
we
Well,
are here.
So Lisa, we were talking about this again on our glorious text chat, which, as I mentioned, is one of the other places I get my news because all AI stuff on LinkedIn makes me sad, and I don't go there anymore, except to broadcast the Health Tech Talk Show and randomly rant about things, obviously. But we were talking about pen stroke risk. This is an example of pen stroke risk.
Pen stroke risk.
Proposed rule, right? It could totally change. Especially with those people marching to Capitol Hill, like Lisa demonstrated for you, like they are going there now. But yeah, this would wipe out a lot of companies. I'm sure they could still bill direct, make physician practices pay them directly, but they're without it being reimbursed. That's kind of unlikely. Also, this was
you have to be at risk for something. You'd have to be like something. There would have to be some other kind of arrangement. Yeah,
you'd have to. Risk. You could do risk sharing or something like that. But like, it's going to wipe a lot of people out. It's going to be kind of sad. Everybody remembers last year. I think United and some of the other big insurers basically said we're just not going to reimburse for this. Remember, and then they switched their opinion on that. So same thing. This industry has been a little bit of a situation.
Loyal Health Tech Talk Show fans will know that this is also related. It's in the same cinematic universe as the CMS access model. And and so that's the other thing is like the smart money is on like this move and moves like this. And all of this is to push folks towards CMS access. Because we know from if you're a loyal watcher, pretty much only the in-person watchers, all two of them of that show we did at the conference with Abe and Gita from CMMI, because our audio is all messed up. Our audio is all messed up. But they said they're like, we are really focused on making this like a permanent part of the Medicare program, getting it out of the experiment status by keeping those reimbursement rates low to ensure that they can show savings to Medicare so that they can expand the model and make it a permanent thing. And so if that's their goal, which they have literally said like they said it directly, quite frankly, that they want access to be kind of the chassis for this type of work, this type of like AI technology enabled RPM, like supported chronic care management. Well, then they want to push as many folks into that. Don't sit on this. They're saying like, do not wait on the sidelines, like get into access now. You can do that. And so we'll see, like, I think it's a clear direction. We'll see if it lands. We'll see what the lobbying march on Washington looks like.
Yeah. Well, and as Mendel notes, a lot of these RPM companies that do stuff externally, like, are pretty good. And it's unlikely that a stressed PCP is going to be able to staff up and handle that and add that onto their services. So I see his point. This was the same 100%. Thing that happened with the CCM codes, right? There were a lot of external companies that went and did that work because the physician practice was like, we actually can't make money on this because the cost for us to insource it is very high. So I see the point there. Also, do you think, like, I love how you framed this, how it was so positive and how it's like, oh, RPM companies just go to the access model. Do you feel like there's any truth to the rumor that like CMS did this to be mean to all the companies that didn't join the access model because they thought the rates were too low?
I mean, it was, you and I noted this. We noted that, that like there were some surprising names who were not on that list. I think it's an interesting theory. I would love to, if anyone has any hot
Yeah.
goss you want to share with
Shan,
us, like
tell us.
signal us. Like we're very much listening. If you work for an RPM company, you lead an RPM company, if you want to come on the show and yell at CMS, if you want to
Yeah. Come
shoot
here.
us some hot goss, like please do. Like we
No.
are, as we've noted, not a real news show, and we have therefore no editorial standards.
Yeah. Yeah. We are not a real news company.
Right.
So call us. Okay, other things that were in the proposed
So
rule.
many
So as
things.
I
Oh,
also
too many
mentioned,
things to cover.
yeah,
Oh
we're
my
not going to
God.
go through them all. We don't have a lot of time, and we want to talk to our real special guest who has real things to say and real experience and is actually a real person. So, but as I mentioned today, one of the only reasons I ever go on X is to read the full thread that Farzad posts whenever the physician's fee schedule comes out. His are mostly focused on his purview, which is shared savings, Medicare shared savings, ACO stuff, value-based care. It's pretty good. You should go through it all. Talks about like basically he is overall, it sounds like happy that we're getting more practices in, especially those that are inexperienced. He would prefer upfront cash payments. That didn't happen this time around, but maybe next time. We'll see what happens. Also, it's only a proposed rule. Maybe Farzad will also march right over the way to Capitol Hill and get that done. Who knows?
Yeah.
All right. Other thing, okay, this might be the last thing about the proposed rule. I don't really know.
There's
We'll get
so
someone
much.
else
We'll
talk
probably
about
have
it.
more. We'll probably have more guidelines, more thoughts on it. We might
Maybe.
bring some more special guests. Who knows?
Yeah, we might bring some special. I'm not going to have any more thoughts. You might, Lisa. We'll see. But anyway, CMS is proposing some changes toward paying for AI in a different way. As everybody knows, some of these things that are like clinical diagnoses type stuff are already somewhat compensated. CMS is making a small move in the direction of being able to pay in a different way by renaming these technologies from software as a service to software as a medical service. Is that what
medical
it is?
service. Yeah, medical
Yeah.
service.
So
Yeah.
this article's funny. It goes
SAMS. Sam's.
Sam's. It goes back and forth, like basically saying this is the greatest thing ever and this is dumb. Like I don't know. Like I don't have any opinions really.
Unclear.
Also, we still don't have an FDA administrator. But there's still some
Commissioner.
commissioner. Is he a commissioner or he or she
I
going to
think
be a
it's a
commissioner?
commissioner.
So the most recent rumors, as you guys remember, a few weeks ago, I don't know, we weren't on the show then. Heidi Overton, who's on the Domestic Policy Council, was named. Everybody was like, huh? Mostly because I don't think her name has necessarily been mentioned in association with this kind of role, but that's cool. I have never heard of the other individuals on this list, but you know what?
That's probably good.
That's
probably good.
That probably is good, Lisa. You are correct.
Yeah. Let it be somebody who is qualified and gonna keep their heads down and try and get stuff done. Fingers crossed.
Yep, we'll see what happens. We're going to be testing the troops for low T.
I'm sorry. I don't want to get anybody into trouble, but
We're
like
going to be testing
the joke
troops.
here is really like too easy. I don't know, man. If there's one thing that like and I totally support this, right? As an now solidly middle-aged person, happy that like there's increasing awareness that people in their middle and older age like might benefit from like hormonal like supplementation basically. Like women are finally able to get like estrogen and also sometimes testosterone, to help with symptoms of menopause. Like,
Yeah.
awesome. Like all these things. If you have like men, and there are reportedly not many men who actually have real, like demonstrably low testosterone at an inappropriate age, like when they're younger, for example. All this stuff is just like gender affirming care, y'all. It's just gender affirming care for the
I heard that
normies.
was that the senator from Vermont who said that today. She was like,
gender affirming care. We support it.
this is gender affirming care, and glad
So
glad that it's
funny.
being supported. I don't know, y'all.
Oh,
Like,
look,
I
we have a
guess.
smart comment from Ellen.
Oh my God, Ellen, what's up, girl?
Ooh, this is amazing.
Um,
Oh, yeah. I just reconcile with the fact there isn't enough money in the pot to pay for what currently costs. An existing healthcare design access is the epitome of that message. And the fact that
hmm.
our incumbent healthcare delivery system largely snubbed our noses to it because it wasn't enough money is so very telling. I agree, Ellen.
Yeah,
Completely agree.
boom. What's up, Ellen? How you doing? How
Nailed
you
it.
doing,
Nailed it.
girl? How's your summer?
That's the
Um,
exact point. Yes.
okay, I thought Matt Bazzelli already left, but apparently it's being
I don't
reported that
know.
he's just leaving. I thought he already left. I don't know, but he's going to go
It's
somewhere else. He's
fine.
doing a special
He's
initiative,
still in HHS.
whatever. Okay. Um, oh, wait,
Oh,
I
that
thought
was
I
that
didn't
dude.
include this. Is the Asper guy or Asper nominee guy? Yeah, I don't know. I don't
Never
think
heard
he
of
did a
him.
great
Never
job.
heard of him. Never heard of him.
Yeah. Okay, something not totally in CMS land, but in grant making land. This is like actually a big drama in health services research and research in general. Is that there's a proposed rule in front of the OMB, or with the OMB, saying that the administration basically is going to have greater discretion over the agenda of the grants that it makes, like basically making sure it aligns with what's going on in any administration. I disagree with this too. Like, what? What?
Yeah.
Apparently, they've received almost 500,000 comments in response, and it's largely seen as like not a great idea. So not great. And then the very next day after I copied and pasted that, Academy Health from their membership, they largely represent health services researchers, as we all know, and support ARC, an agency we have not heard from in the past year and a half. A lot of their staff has been gutted out. Hundreds of grant cancellations occurred. So this is really similar to when we saw the $2 billion in SAMHSA grants being just cut, like with a letter that kind of didn't say anything, all kinds of stuff. So that happened. Very uncool. And I at least have not heard a response from the administration other than what that letter says, which is these do not align. And sorry. There's not even a sorry.
Yeah, this whole thing, it's just such a distraction. It's not a lot of money that's being saved. It's not proposing an alternative for how this work gets done. It's just like, okay, what are we doing?
Yeah, well, it's from what I've heard, and I'm not a PhD. I have a PhD in a school of hard
Weird,
knocks, but
weird.
I know. But a lot of these grants like aren't done. Like they're not letting them finish. So it's also
So
like,
you're not even
oh,
getting the value
yeah,
of like anything. It's just like, I don't
that does
know.
seem like a waste of money. It's like, oh my God, like whatever. Anyway,
Yep,
uncool. I
uncool.
would love to hear what's going on here. Haven't heard the story. Other interesting news, and then we can get to our real life special guests. Mostly, I included this because I would like to continue making fun of ARPA-H program names.
Oh, I
I'm
love
sorry. I
them.
I think
Rest,
I think
rest.
these names are so ridiculous. Like, just call it whatever you want to call it. They like force these programs into ridiculous names. Okay, so
Cats march into Capitol Hill to complain about our page
like stop
program
naming them
names.
stupid stuff. Just call them what they are. Like comms 101. Okay, restorative and health enhancing sleep time. Like I don't know, like the
I
sleep
love sleep.
I don't
Sleep
know.
is great. I don't get
I'm not
enough of
saying
it.
this is a bad program. I'm saying,
Big
can you
fan.
please start naming your stuff things that matter? Like, why
Big
does the
fan.
government generally believe in these all like laws or like? Why can't we just call these things what they are? Like sleep time. I don't know. I can't even take it. Okay.
I don't know.
Also related, sort of related, and two new innovative things. HHS and the VA they've signed an MOU to collaborate on what they're calling rapid acting mental health treatments. This includes ibogaine, other psychedelic type research. So
I don't think Ibogaine is rapid acting, by the way. I think it's like a whole
they
like
name it
24-hour situation.
specifically. Yeah, they name it specifically in here. So I don't know, Lisa. I've never done it, but I would love to hear what people think about it.
I think that like ketamine is much more rapid acting than Ibogaine, but
I
sure.
mean, I don't know, but I actually I think this kind of collaboration is
I'm
great.
I'm
Like
I'm
I'm
fine.
here
Like
for it.
I'm so supportive of, psychedelic treatments for PTSD in veterans and other people. Like I think it's totally makes sense to be
Yeah,
testing and
like
trialing and providing
serious
and like
stuff.
I just like that I just that's so important. I think there are very a lot of people with untreated or treatment resistant PTSD and other serious conditions that need help. So let's find
Yeah,
something.
100%. Let's see how it goes. Now I think we're entering into fun news. Are we? Okay. Oh,
Fun
this
news.
is just exciting in general. So remember we've had
This
Ann
is
Zink on
cool.
the show. She runs Pop
Yeah.
Hive, a collaboration out of Yale. She's basically convincing everybody to provide Pop Hive, her project, with public health data that's de-identified. To be clear, her big tagline is public health data should be publicly available. Obviously, it's de-identified. No one's going to like find anything about your kids or your mom or whatever. And now they have an integration. They're a public connector with Claude, which I actually used today. I was like, hey, I have like a little bit of a stuffy nose. Like, what are RSV rates down here? And it'll pull it all from the Pop Hive data, which is pretty cool. So,
So cool.
yeah, I mean, go
No,
and go
Pop
the
Hive
team
is
here.
doing great work. Like, yeah, they're doing fantastic work. Like all about getting data out, all about like engaging with, tools and systems that exist in the public. Really cool. Good work,
Yeah,
guys.
you go, girl. And she
You
has
are
a
awesome.
co-founder. I don't know who that guy is, but I'm sure he's very smart as well. Okay. Okay. Also in Nerdland, big news in interoperability, national networks. Everybody knows Jay Nakashima was like looking for a successor and has he retired? He's almost retired if he hasn't.
Who knows? I feel like he's going to be one of those guys who just is a cool consultant hanging around. And that's
Yeah.
great because Jay's a good guy. So I think we're going to see him again.
Yeah. I
He's going
hope
to
we're
try to
going to
retire.
see.
It's not going to work.
Yeah, I hope that happens because I like Jay, I like hanging out with him at the bar. So I hope that he, in fact, does pursue that next chapter, whatever it might be. Uh, and the new CEO has been named. It's a familiar face, Doug Beatsman.
Yep. Doug
Yeah.
Dietzman was recently at BCBS Association, but also longtime HIE guy.
Mm-hmm.
So yeah, familiar face
Yeah.
at the helm of
Congrats.
eHealth Exchange.
Congrats, Doug. See you around. We will see you around at the
That's totally,
conference bars, at the nerd conferences. We will see you
that's right.
there.
That's right.
Um, I would be remiss if I didn't quickly mention the Epic drama, probably most talked about, potentially most influential company in our sector. There has been some secession drama going on at Epic, which, as everybody knows, is privately held, is headed by founder and CEO Judy Faulkner. I think everybody, well, Lisa, you probably know more about this. You want to just do a little dirty?
Yeah, I mean, Sumit Rana was the president, is still the president, and he has been with the company since day zero, first job, only job, as far as I can tell,
Mm.
and for a really long time. Original like software developer on my chart.
What?
In case you want to know where to send your hate mail. Sorry, just be nice. Sumit's a very nice guy in person, but he did create my chart, and it causes a lot of people a lot of consternation. So like with the company forever, has been the president for some time. Everybody thought Sumit is gonna become the next CEO. And he's like, I quit. He's like, I gotta spend more time with my family, which everyone knows, everyone in corporate land knows that as code for I didn't get something I wanted. People close to the source say, no, that's not true. He just literally didn't want to be the CEO of Epic and wanted to spend time with his family. So we'll see. And then that set off like a bunch of and then apparently like a bunch of other people are now like top people who've been there for like 20, 30 years are like, I'm out
Mm.
also. So
Mm.
I think Seth Hain, no,
Yeah, Seth
please,
Haynes.
if
Seth Haynes
I think
out.
he's out, a couple other people who've been there for 20, 30 years, like SVP, like, and they make up their own titles, but like really truly like the senior executives of the company working on R&D and like stuff like that. So yeah, like as you can see here, the Game of Thrones has been referenced in meme by our friend Brendan Keeler, and that's the best thing I can that's how I can describe it. There's some shuffling happening, and it's a pretty big deal.
Yeah, pretty exciting. We'll see what happens. I don't know what's going to happen, and but apparently there are 4 people splitting up Sumit's job, and we'll see what happens. Who knows?
So she's not naming another president that's what I take from that, unless they're all
Yeah,
president of XYZ, president of ABC, whatever, like,
yeah.
right,
I don't know.
like
I don't know.
uh,
I don't know. I
uh,
don't know what's going to happen. We'll see. Maybe an external search. Look forward to being that external search
I
firm.
sincerely doubt they would
Lol.
bring it. They will never bring in an external anything if you know
Probably
anything
not.
about
Probably not.
Epic.
Probably not. Probably not.
Yeah.
Anyway, Lisa and I are going to all the normal places that we normally go, but special shout out to the Adapt conference run by a good friend, Tina Grande, who is the lead for the Healthcare Trust Institute. Just had to like think about that one real quick with all the healthcare names going out there. But we love Tina. We love this group. And so we are actually like, I think we're like the conference closers out in Santa Fe.
We are.
On October 16th, the conference starts on the 14th. Be there or be totally left out. All of our friends are speaking there too. It is apparently magic carpet themed, which is why we are riding a magic carpet here. And we're very excited. It is unclear who we are interviewing. We are doing a live show on stage in front of everybody. I don't know who we're going to interview. Like, I don't know.
If you guys want to see this clown show in person live, you should definitely come. We have not done a live show before, so thanks to Tina and the team for like making it happen.
Yeah.
Like
yeah,
we've
so
done we do live shows all the time, but like live on stage, like we're the show is the main show. Yeah. That will be fun. We might have to prepare for this. This is weird.
I don't know. I kind of hope it'll even tell us who it is until the last minute.
That would be funny.
See. We'll see what happens. All right. That's all we've got for random news that we missed over the past couple weeks. Now we're on to real live special guest.
Hi, Melanie.
Hi. Hey, glad you made it. Sorry about the technical difficulties. It's a hallmark of our show.
It's a very typical thing that we do.
Not a problem.
Well, Melanie, while we were busy totally rescheduling our show because we set it to go live at 3 a.m. And setting up this new one, and you were getting in, we probably incorrectly told our audience who you were. Would you please introduce yourself along with what your role is?
Sure. I'm Melanie Bush. I am the Deputy Secretary / State Medicaid Director of North Carolina Medicaid. Here, we're part of a bigger organization in the North Carolina Department of Health and Human Services.
Okay, right on. Is it normal to be both the Deputy Director and Medicaid Director?
I'm Deputy Secretary to the HHS Secretary, but I'm State Medicaid Director. Yeah.
Okay.
I think it lives in I think every state has a different, where is this exactly? How does it sit? But yeah, it makes sense.
Like Marco Rubio, where you have 100 jobs.
No, thank you.
Crossing multiple countries.
Yes, exactly.
Yeah. Well, what's your background? We have lots of, I'm sure your team told you this, but we have had a lot of North Carolina going on in this show.
Oh, no, they did not. Yeah. That's great.
The great thing about this as well, we have not prepared for your arrival on the show. We have interviewed multiple of your friends, so we do know things about your state. So yeah, tell us your background.
So I actually am from North Carolina, born and raised in Western North Carolina, beautiful Blue Ridge Mountains. I went away to school and worked for a while and moved back to North Carolina in 2007. I started out in Medicaid as an intern for the Texas Medicaid program because I was in grad school in Texas, and moved back to North Carolina, and I've been working in Medicaid ever since. I did the Medicaid budget for the General Assembly for a couple of years, and then since then I've done policy and operations for Medicaid, and I'm been here probably on and off since 2011. So yeah.
Wow.
I'm also on the board of the state health plan for teachers and state employees. And yeah, that's sort of the health world that I live in.
Yeah. So you know what you're talking about, basically. That's great. Okay. So one of your friends, I'm sure, Cody Kinsley, writes a hilarious newsletter that he titles FOK in all caps, which I read whenever he sends it. Which stands for Friends of Cody, but I think it sounds like whatever you want. But in that newsletter, I think it was this week or late last week, he talks about the Healthy Communities pilot potentially coming back.
It's got refunded, right?
Yeah, so it has been reborn. It's super exciting. We have a Healthy Opportunities pilot program that basically provides food, transportation, housing, and assistance with interpersonal violence. We did this program for a couple of years, and we just released in June our summative evaluation report that shows that if you invest in these things upstream, you can actually save $165 per member per month, net of the cost of admin and net the cost of the service. And so everyone in North Carolina has been talking about how unsustainable the Medicaid budget is. And so we were like, here's a way to bend the cost curve. Check it out. And we got a pittance, but we are very grateful for it. We have $25 million. So we did used to have 130 million, so you can see the difference. It's a little bit of a drop in the bucket, but I think that, we showed them that it actually works, that keeping people healthy is actually cheaper than treating illness, and giving them food and safe housing and transportation goes a long way to keep folks out of doctor's office. So yeah, I'm excited about it.
So I think you mentioned a few of those pieces. Sorry if my Wi-Fi is going out, like I don't have any infrastructure down here in the great city of Atlanta and the storm, but you mentioned a few things that you're focused on there. Would you just highlight for us? You have 25 million, not 130. What are the pieces of that program, or how are you keeping it going given that reduced budget, which is obviously great, but not as much?
Yeah, so we are in the process of reimagining what it looks like. I told folks earlier this week, because we do want the General Assembly to continue to invest in the program, that we want this to be the most impactful $25 million we have ever spent in our entire lives, so that they can continue to grow the program. We are probably going to shrink the geographic area right now, or the old program was in 3 different rural areas of the state. We're probably going to have to shrink our footprint, and we're probably going to have to shrink our service array. I think that we want to show still a return on investment and show that it is bending the cost curve. So we're going to have to rethink the way that we have designed the program, but the budget just passed like 2 weeks ago, so we haven't figured it out just yet. But I do want to say that that's the first time we've had a budget in 2 years. So we're very pleased about that too. Yes, very great to have a budget.
Awesome. Other things,
it's really great.
In the Lisa, did you have any questions about that?
No, I just think it's really great to have the chance once again, because hopefully you'll say like, yeah, look, this is what we did. We're still doing this. You should fund this because it literally saves money.
Yeah, and everyone's pointing to North Carolina as a model, and I think that the way we did it makes sense, but it's also just not rocket science either. I think that it's tried and true, and it's been demonstrated in other parts of the world for decades. So I'm excited that the United States is catching up.
Yeah. Well, yeah, you guys, North Carolina has, at least on our show, always been something that people point to and say, well, they did a cool thing here. I know you guys have the whole medical debt thing. Another affordability thing that was called out in the Friends of Cody newsletter. Sorry to have him leading the show from his newsletter, but talked about the affordability model that North Carolina has started, and how I think there's some sort of council you guys are leading or something like that.
Actually, yeah. The first meeting is next week. We have a healthcare affordability commission, and they're going to be looking at ways to bend the cost curve. Healthcare continues to increase at an exponential rate. We pay in North Carolina, I guess, higher rates than the surrounding states, and so they are bringing together members of the legislature, the state treasurer, the Secretary of Health and Human Services, and state budget director as voting members. And then they have sort of, a sample of stakeholders from all the different industries to talk about how we can really address the fact that this is a increasing crisis for employers, for state budgets, for everyone. Healthcare is getting more and more expensive, and what we can do to slow that growth a little bit.
Awesome. All right. Listen, we just talked about Cody like way too much. What are your priorities you want to get done? I mean, this is like a cool job.
Yeah, so we are super excited. Unfortunately, a lot of our priorities are set for us by outside entities. So the biggest thing that we are doing, as you can probably imagine, is trying to comply with work requirements in the Medicaid program starting on January 1. So we are, I think, pretty well positioned to have a minimal viable product on January 1. We personally do not want to implement this, but we are required to by federal law. And so we have been focused on trying to integrate all the different data feeds that the state of North Carolina has access to. And luckily, we have a government data analytics committee that we can pull from. So we're trying to automate as much as possible for work requirements to make sure that people who need health care and are eligible for Medicaid continue to receive it and don't just fall through the cracks because of some sort of administrative requirement. So we're going to start pulling health information from the Health Information Exchange. We're going to be pulling education information from public schools and community colleges, and university systems, talking about, workforce development programs, people participating in that. And then, of course, we have all of our Medicaid data that we can use to determine whether people have to show that they're working 80 hours a month or not. So that's really the biggest focus of.
I was like, 80 hours a week, that's my week.
No.
So funny. Month is per month. The work requirements are per
80
month.
hours a month. Let's be clear. Yes. So that's the big focus. But we are also, just sort of related to the Healthcare Affordability Commission, we're also really interested in looking at what's working in North Carolina Medicaid and what's not. We have been doing Medicaid transformation for the last 5 years. We moved from primarily fee-for-service to managed care. And so we have an outside entity taking a look at North Carolina Medicaid, benchmarking us to other states, seeing where we're strong, where we're not. And then they're going to do sort of a deeper dive into where we should really be investing our money to get the best health outcomes. So those are the two big priorities for the next couple of months. And then, of course, there's just like keeping the train on the tracks and keeping it moving and implementing all the fun things that they put in the budget. So yeah, it's going to be an exciting year. Just trying to get to January. I'm in like survival mode until January. Yeah.
I bet. I was just talking to somebody else about this topic earlier today and just trying to understand when a state, even a state like North Carolina that's had a lot of focus on this, really is looking at modernization and using technology and using data, what are kind of the top barriers you all are seeing? You mentioned going out to, and I know North Carolina has invested a lot in its health information exchange and had a lot of focus there, but probably even today, all the other agencies, all the other programs aren't using all the data that's already been invested in. There are still data silos. Like, what are the top issues you all are experiencing when you're trying to, modernize and upgrade all these systems to meet whatever is coming down the tracks next?
I would have to say that data quality is our biggest barrier. And we are really trying, we are in the middle of updating all of our Medicaid infrastructure and technology, and we're really trying to be very tight on our data governance and our data dictionaries and all the requirements for all of our different platforms. We currently out for bid right now for a data analytics platform and for a provider enrollment platform. But we're trying to make sure that the data that we have coming in is correct and quality and that we can use it and it's actionable. A lot of the stuff that we see coming in from even health plans or from the HIE isn't necessarily as clean as we need it to be and as precise. So that's a big challenge. I think, just in government moves at a different pace, and I think that's also a challenge. Technology is much quicker than government and procurement, state procurement laws. My God, it takes a long time to get things in place, and it has very real impacts. And then when you have it would be one thing if we were just North Carolina Medicaid, but then we also have 15 health plans that we've got to exchange information with, and we've got all these different partners that we've got to exchange information with. So actually connecting all those pipes, it takes some time. So that's really part of it too. I think also convincing members of the General Assembly that we need this. Like, we're a $45 billion program, and they're like, but why are you spending so much on technology? I was like,
you're like, what are we gonna do? Fax it to each other in our what?
Yeah.
Ridiculous.
So I think it's helping members of the General Assembly understand that this will help with the whole fraud, waste, and abuse conversation. This will help with the whole, efficiency. This will help with staffing and all the reporting and all the oversight that we need. It's really just making that case to them. And luckily they did. They gave us money for our Medicaid infrastructure in the budget that just passed for the first time in 2 years. And they did give us some funding. So that's exciting. But yeah, the big challenge is the data quality and then connecting all the different streams.
Yeah, a lot of times when we talk to Medicaid directors in other states, they say it's varying percentages, but they'll say I'd say the worst was a gentleman who said 89% of my time is spent talking to legislators to try to convince them that they should keep our program going.
Yeah, no, it's true.
Yeah.
It's absolutely true. And they've got, lots of competing priorities. And I get
Right.
it. Like, I have kids in the public school system and I want them to fund education, but Medicaid keeps taking up a bigger and bigger slice of the pie. And so people are starting to get very tired of me always coming with my hat in my hand.
Yeah.
Yeah. I have a question. So on the one hand, right, we have these massive cuts to Medicaid, and states and Medicaid directors have to respond. And like you said, you have to implement things that are required by law. You have to change different parts of the program as required by law. And then, on the other side of it is probably just like the healthcare delivery system. And, you're like, so fewer people are going to be covered, and they're going to show up at your door, and some of you are required to be providing charity care, and you may not be doing that. But probably in general, I assume you're also just hearing on the other side from the healthcare delivery system, in particular safety net institutions, and those who are serving people on Medicaid or people who are formerly on Medicaid. Like, what are they saying about this?
Well, it's interesting. We spent a good amount of time actually last year in Washington, D.C., trying to convince our federal delegation that these changes that were proposed in H.R. 1 were only going to make everything more expensive. And that honestly is what's going to happen. We're going to see more people who have uncompensated care, and that is going to trickle throughout the healthcare delivery system and make everyone's healthcare go up. We did have limited success with our federal delegation, unfortunately. Didn't move the needle as much as we wanted to, but we were able to convince Tom Tillis, the Republican senator from North Carolina, to oppose H.R. 1, and because he understood that it's going to be taking at least $50 billion out of the North Carolina healthcare ecosystem and economy. And that's going to have real impacts. It's going to have impacts on rural hospitals and our providers and access to care. It's going to have impacts on our ability to be seen quickly. It's going to have impacts on quality. So, yeah, we talk about it a lot. And I do hope that it's a topic of conversation for this Healthcare Affordability Commission, too, because it is going to impact not just Medicaid. I mean, this is all Medicaid related.
Right.
This is money coming out of the whole economy, and this is money coming out of the whole delivery system. So we are the largest insurer in the state. And a lot of these changes are going to take so much money out that helps, safety net providers and rural providers most of all.
Yeah, definitely. Any savings is like somebody's revenue, right?
Yeah.
Exactly. And nobody, like, that's one of those, like, and we always say, like, well, if you win, like, who's losing?
Who's losing?
And, and is that if you're successful, who makes less money? If you're talking about like an investment or something new, but the same thing for any savings. If you're finding savings, if you're cutting dollars out of the budget, like, that's most likely like the revenue or the overhead or the profit, God forbid, of like some other company or entity on the other side.
Absolutely. And the thing that I've also told folks, because they were considering cuts at the state level too, people are still going to get sick. Like, cutting the budget doesn't mean that people won't get sick. And so they're going to still show up and need health care, and somebody's going to have to pay for it. So it's more efficient to pay for it through the Medicaid program than to have the uncompensated care that we were talking about. Cutting the budget doesn't mean that people are not going to use the healthcare system. That's just not how it works.
Right,
yeah.
right.
All that lettuce, all that cyclospora lettuce.
Yeah. Taco Bell.
Poor Taco Bell. Yeah.
That's what I said.
She was Taco Bell.
I said poor Taco Bell. They're just people
Bell.
like Taco Bell. It's whatever.
Yeah, it does suck me wrong. Oh, yeah. So Melanie, I know the Rural Health Transformation Program is big, and I'm sure every state's doing it differently, but I assume at least you're collaborating on how that money could be spent. Is there anything you can share with us on that?
Yeah, so we actually just had CMS on site in North Carolina this week to talk to us, and then they went out to Western North Carolina, and you all know that Western North Carolina got hit really hard in Hurricane Helene, and so they talked about that. But basically, North Carolina is building upon, I think, some of the success that we've had with the Healthy Opportunities pilot, and we have these things called Roots Hubs that are going to be local hubs throughout the state in 6 regions that are really going to be sort of the incubators of how we spend this rural health transformation money. And we're investing in, we can't actually pay for services, which is crazy, but we are investing in, provider education. We're investing in primary care, value-based payments. We're investing in lots of different things, but it's really going to be driven by the local communities and what they think that they need. So we're looking forward to it. I mean, there's still a lot to be done. It's very new, but and we really just have a couple of staff, and then the rest of the department sort of supporting them. But it's exciting, and I'm from rural North Carolina, so it is something that I am a big believer in. I tell people when I was growing up, I used to want braces because I lived in a county where there wasn't an orthodontist, and the orthodontist came to town on Tuesdays. And everybody got to get out of class to go get their braces tightened. And I didn't have braces, but it's a real thing. Like growing up in a place where you don't have an orthodontist. I mean, that's crazy. There's not a delivery hospital where you can go have a baby in many of our counties. And in the mountains, it's quite treacherous to drive fast when you're in labor. So been there and done that.
I had to go. I had Medi-Cal and Denti-Cal as a kid, and there was only one dentist, not even in our county, but in the county over, who accepted Denti-Cal. I remember that. So similar. Like there's not much there out in the rural parts of America. We don't have the big fancy hospitals or even specialists.
That is cool though, what you're doing. It almost sounds like you're taking a decentralized community first approach, which is not the approach that I hear from a lot of states where it's like state down, governor driven. That's cool.
Yeah. No, I'm excited. I hope it works. We'll see.
Yeah. Well, what else? We're almost out of time. Is the weekend, which is why we hold the Health Tech Talk Show on Fridays afternoon, so we can have more fun. But what else are you excited to tell all of our millions of loyal fans?
North Carolina, I could talk about Medicaid forever and ever. I will say that, I've already talked about the healthy opportunities. I think that's a big win. And I think that everybody needs to help us spend that money wisely. We are, again, in the process of modernizing all of our technology. We are in the process of evaluating what we've been doing. We don't have big implementations this year, so but we do have work requirements, which is like the biggest change in Medicaid eligibility ever. So we're just using this opportunity in this year as sort of like a rebuilding year to like strengthen what we've already built over the last couple of years, make it stable, and then try to simplify where we can, because I think sometimes, shockingly, we over-engineer things in state government. And so we really want to focus on streamlining things for our beneficiaries and for our providers so that they get the best experience they have. So we're doing a lot of that this year. There's not a whole lot. We have, a budget, which is great, which means we have stability. Last fall, we were cutting rates and people were suing us, and it was a whole political mess. So we don't have to worry about that this year. I think what we're going to focus on this year is really making sure that what we have in place is working for the people of North Carolina and that people are getting healthier. Everybody's talking about savings, but I'm really still focused on making North Carolina healthier, and that's going to be our focus.
Well, that's probably just a different way to say savings that most people don't realize. So good for you.
It's true. It is.
Awesome.
If you're healthy, you go to the doctor. That's right.
Right on. Well, hey, Melanie, it was a pleasure. Sorry about our technical difficulties, but I
Not
feel
a
like
problem.
our return from our summer break needed to have some technical difficulties. So,
before she goes,
you
we
got
got a
fan.
comment
Oh,
tag to you
you
from
got
Dee
a
from the Sequoia
fan.
Project. So
Nice.
they're happy to help as well. So just a note.
Yeah.
Thank you very much. And thank you both for having me. This has been fun.
Cool. We
Thanks
look
so
forward
much,
to watching
Melanie.
your flawless execution to get all this done. Having you back
Yes.
on in February when you've had a nap
Yeah.
to tell us all how you got it done.
Sounds great.
Cool. Well, thank you,
Awesome.
Melanie. Yeah.
Thank
Happy
you.
weekend, everybody.
Happy weekend. Bye-bye.